Hi, everyone. Thank you so much for joining us today. Today, we are very excited to have with us our expert neonatal hemodynamic specialist, Dr. Amy Stanford, who will be covering the topic of hemodynamics of vein of Galen malformation. Dr. Stanford is a clinical assistant professor in the Division of Neonatology at the University of Iowa, where she completed her fellowship training in neonatology and neonatal hemodynamics. She is the lead clinical lead of the hemodynamic program at the University of Iowa, as well as the director of the outpatient hemodynamics clinic. Her research interests include chronic pulmonary hypertension and cardiovascular outcomes of extremely premature neonates. Joining us as well today are three remarkable panelists, Dr. Angelica Vasquez, Dr. Johanna Fifi, and Dr. Mary Mullen, who I will be introducing later on. So after Dr. Stanford talk today, we will have a Q&A session in the end. So please feel free to put your questions in the Q&A chat box for us.
Thank you, Pearl. And, everything still look good, Pearl?
Yes.
Okay, sounds great. Thanks everyone for having me today. I'm excited to speak today about the hemodynamics of vein of Galen malformations, which can be a really challenging patient population to take care of who have ever-changing physiologies. So I have nothing to disclose. So we're going to start today with a case, and it's a term infant who's several hours old now, who's presenting with hypoxemic respiratory failure, who was found to have a pre- and post-ductal saturation split in the NICU. Laboratory evaluation showed an acute lactic acidosis. So, as many people would, the team got a chest x-ray. You can see here that the heart is quite enlarged, taking up the vast majority of the chest. And so now the clinical team is concerned about potential congenital heart defect. So a cardiology echo was obtained, and it showed RV dilation with severe pulmonary hypertension, a PDA that was mostly right to left, and then buried in the report was reversal of flow in the arch. So based on all of this, a very astute neonatologist went and listened to the head of the infant and heard a bruit, which ultimately led to a diagnosis of vein of Galen malformation. And this infant was then referred to a tertiary NICU center for further care, where it actually happened to be one of our panelists, Dr. Angelica Vasquez, who was our HD fellow at the time, who happened to be on her NICU call that night, and myself as a first-year faculty on NEO call. And I remember that Angelica was very excited and yet terrified at the same time, appropriately so, and she kept asking me, what does a normal vein of Galen echo look like? And all that I could keep thinking was, I don't know what I'm supposed to see here. We hadn't seen one as a hemodynamic faculty yet. We didn't have one by chance during my hemodynamic fellowship, but that's fine. We have Patrick and Reagan. They've seen vein of Galen's before, but as luck would have it, they were not available. True story, they were on their way to Sweden and were not available. So what Angelica and I did was, while this patient was coming, very thoroughly and quite often that night, kept reviewing this paper written by Reagan, talking about a case report of 2 series, but importantly had gone over the physiology and the approach to management. So in today's talk, we are going to speak about the physiology of vein of Galen malformations, talk then about management strategies in order to best care for these patients, as well as spend a little bit of time on what future considerations for the care of these patients looks like. Vein of Galen malformations are luckily extremely rare, with an estimated incidence of 1 in 10,000 to 25,000 births, and they account for 1% of all congenital anomalies and 30% of pediatric vascular malformations. As I mentioned earlier, these patients have complex and ever-changing physiologies, and it is critically important to identify the correct phenotype early and provide correct treatments. And this requires a really in-depth understanding of cardiovascular physiology with comprehensive and serial echocardiographic assessments and targeted therapies. It's the correct identification of these unique hemodynamic phenotypes which allows us to clarify when is the optimal time for endovascular intervention, which can hopefully potentially improve our outcomes of these patients. There are really multiple cardiopulmonary considerations in the management of vein of Galen malformation. Remember, in the fetal period, we have the low resistance placental circulation, and that is going to be balancing that low resistance systemic shunt in the vein of Galen, which is likely protective from heart failure in the fetus. Following birth, however, those changes in systemic and pulmonary vascular resistance in the presence of this low resistant preductal left to right systemic shunt contributes to significant hemodynamic changes early in the neonatal period. Remember that the vein of Galen is a low resistance circuit that acts as a vacuum, sucking blood up preductally, leading to increased return via the SVC. So what are some of the classic echocardiographic features that should raise your concern or suspicion for a vein of Galen if you see these on an echo? The first one you really want to think about is if you have a dilated SVC, robust SVC flow. And so you can see here in the subcostal view, we have our right atrium, and we have a really robust SVC flow coming off. And when we Doppler that with our pulse wave Doppler, a quite robust VTI. And what we'll actually do in our patients with vein of Galen as we follow them serially is we'll actually trace the VTI of the SVC flow to kind of trend how our high output cardiac failure is and to trend over time. Other clues to think about on echo that should raise your concern for vein of Galen would be dilated head and neck vessels off of the aortic arch. So you can see here our view of our aortic arch, and you can see we have really, really quite dilated vessels. In fact, our vessels off of the aorta are as big, if not larger, than the aortic arch. So this should raise your concerns for some sort of AVM, especially in the head. And what you'll see is when we Doppler, in both our pre and post ductal pulse wave Dopplers, is we're going to see reversal of flow. So we'll see reversal of flow in the proximal arch, seen here, as well as reversal of flow, especially during diastole in the descending arch. These are abnormal and should raise your concern for a vein of Galen. And additionally, frequently seeing a dilated right heart, sometimes there's dysfunction, and these views, so on our apical forechamber, seeing our very dilated right atrium and right ventricle, and here on our parasternals, seeing that we have a flat intraventricular septum, and that our RV is about the same size as the LV. These pictures alone just kind of mimic what you might see in a pulmonary arterial hypertensive crisis, and as we go through the rest of the talk, you'll see why we need more than just a few images in order to diagnose vein of Galen based on echo. So in order to provide the best possible care for these patients, it's really critically important to identify the correct physiology. This can be extremely challenging, and it requires the use of high-quality echocardiographic assessment. I'm going to highlight the need of why we need high-quality echo assessment by going through an example case again. So this was a very similar case to what I talked about in the beginning, term infant hypoxemic respiratory failure with concern for acute pulmonary arterial hypertension clinically. So a cardiac POCUS was performed, and you can see again, there's this dilated right atrium and right ventricle, a flat intraventricular septum. The PDA was assessed, and it was large, bidirectional, and mostly right to left, as seen here on the Doppler. So the team thought they were dealing with just resistance-mediated pulmonary arterial hypertension, so they started inhaled nitric of 20. But unfortunately, that patient had a clinical decompensation with worsening oxygenation, decreased perfusion, and worsening lactic acidosis. So what went wrong? We'll come back to that. And I think what that case highlights is that there is a role for T&E in the care and management of vein of Galen. T&E is a really important tool and is used in both pre-intervention stabilization, during the intervention monitoring, as well as post-intervention monitoring and helping determine next steps for the patient. And we'll go through each of these areas. So the initial medical management with T&E starts with first identifying the correct physiology. Next, we need to apply treatment strategies in order to stabilize and optimize the infant. And finally, helping to determine when is the optimal time for embolization. There are 3 cardiovascular phenotypes of vein of Galen malformations. The first and most common is flow-mediated pulmonary hypertension. Next, there's resistance-mediated pulmonary hypertension. And last and least common is just isolated right ventricular dysfunction. So in flow-driven pulmonary hypertension, the SVC in the right-sided heart structures are dilated and they might have dysfunction. And there's increased pulmonary blood flow. And as a result, there's increased blood return to the left side of the heart and increased left ventricular output, which is then primarily diverted to the cerebral AVM because it's that low resistance vacuum up in the brain. Postductal systemic circulation depends on the presence of a PDA with a right to left shunt. So this is that pseudo-coarctation physiology. Clinically, these patients present with minimal oxygen needs, lactic acidosis, oliguria, that's all consistent with the pseudo-coarctation physiology. The PDA flow, do note to remember, is dependent on the aortopulmonary pressure gradients. Additionally, on echo, in flow-mediated pulmonary hypertension of vein of Galen's, there is going to be extremely high cardiac outputs of both the left and the right ventricular outflows. So usually these are greater than 300 mils per minute per kilo. So in the case of flow-mediated pulmonary hypertension, giving INO can have serious and really detrimental side effects. And why is that? Well, we need to remember that pressure equals flow times resistance plus left atrial pressure. So in flow-mediated pulmonary hypertension, the pressure is elevated secondary to increased flow and increased left atrial pressure. So as we just went over, these infants are dependent on a right to left shunt at the PDA in order to perfuse the postductal circulation. So when we give INO, what we're doing is decreasing the pulmonary pressures, leading to a reversal of that right to left shunt. Now it's a left to right shunt at the PDA, and therefore we're decreasing postductal blood flow. So what do we do in order to support these patients with flow-mediated pulmonary hypertension? And that can include supporting cardiac function, and particularly if there's any dysfunction, so using an inotrope like epinephrine or dobutamine. But most importantly, we need to maintain at least some right to left ductal blood flow. So this includes utilizing prostaglandins in order to maintain ductal patency, as well as minimizing oxygen. So sometimes what we'll have to do is set lower SAT goals and target higher CO2s and use those strategies to maintain at least some portion of a right to left shunt at the PDA to supply the postductal circulation. So moving on, in resistance-driven pulmonary hypertension, in that phenotype, we again have similar dilation of the SVC and the right-sided heart structures from increased flow driven by that large cerebral AVM. And the right heart dilation can contribute to some amount of RV dilation. But in this case, pulmonary blood flow is limited due to our increased pulmonary vascular resistance. And thus there's decreased preload to the left heart and ultimately decreased left ventricular output. Given that this is still a low resistance shunt in the vein of Galen, there may be a right to left ductal shunt based on those aorta pulmonary pressure gradients, and blood is going to still preferentially shunt to the cerebral AVM, compromising postductal blood flow. These patients present with severe hypoxemia and mimic the classic acute pulmonary arterial hypertension presentation. So treatment includes invasive ventilation, using sedation and muscle relaxation in order to try to decrease our pulmonary vascular resistance. Again, the need to maintain a PDA to avoid RV failure in this standpoint, and sometimes utilizing pulmonary vasodilators like inhaled nitric oxide. But in these cases, we still need to be really judicious with our use of pulmonary vasodilators like increased oxygen or INO. Because while those can improve our pulmonary blood flow and therefore increase our LV preload for systemic circulation, it's important to recognize that the dynamic nature of this physiology and the need for serial and oftentimes daily, if not more often, T&E evaluation. Because in patients whom the PVR falls, pulmonary blood flow and pre-ductal cardiac output will increase and can lead to then that classic high output flow state and features then of flow-driven physiology. So therefore, frequent reassessment is needed in order to prevent the development of significantly increased pulmonary blood flow and reversal of the ductal shunts that are crucial for systemic perfusion. The final phenotype that I mentioned earlier is isolated right ventricular dysfunction, and these patients are characterized by increased oxygen need and decreased markers of perfusion. On echo, we'll see measures of decreased RV function, so doing the fractional area change, as you can see there in the middle, TAPSE, the tricuspid annular plane systolic excursion, looking at tissue Dopplers of the RV, those all will be down. And treatment includes the use of inotropes in order to support cardiac function. So back to our case earlier, where remember they thought the baby had resistance-mediated pulmonary hypertension based on a cardiac POCUS, and the baby got worse with inhaled nitric oxide. A T&E was then performed on this patient when they got worse, and the echo demonstrated hallmarks of flow-driven pulmonary hypertension from the vein of Galen with a pseudo-coarctation physiology, as evidenced by high cardiac outputs seen on the right. The team stopped the nitric, started prostaglandins at the lowest possible dose, though, in order to maintain ductal patency, but to avoid additional pulmonary vasodilation, and the teams used strategies to promote a right to left shunt at the PDA. So hopefully this little case kind of highlights why you need a comprehensive echocardiographic assessment in order to fully determine the underlying physiology. So after stabilization and optimization, the mainstay treatment for vein of Galen is endovascular embolization via transvenous, transarterial, or a combined approach in order to embolize those feeder vessels to the malformation. It's imperative that this occurs in a staged fashion in order to allow continued hemodynamic stability and secondary to the limitations of the amount of contrast that's able to be used in such small infants. It's important to note that not all infants with vein of Galen will require neonatal intervention, but in those where they cannot safely discharge home without some sort of intervention, a staged approach is best. So when are these patients ready for embolization? And typically that's once they're medically optimized as much as we're able to, balancing both pulmonary and systemic blood flow, and allowing for time for the PVR to fall as much as it's able to. This usually takes several days with typically serial T&E assessments in order to determine when this PVR has reached its nadir. But we do have to remember that sometimes the PVR isn't going to fall as much as you would typically expect, secondary to in utero pulmonary vascular remodeling. Another important thing is that clinicians really need to recognize cardiovascular changes that can occur both during and after embolization. The job is not done just getting them to the embolization. close monitoring is needed during and after, because these patients are at risk for post-interventional cardiorespiratory instability, similar to the features seen with post-ligation cardiac syndrome. So in patients who are undergoing interventional closure of the PDA, it's very similar to what we see when we have embolization with the vein of Galen, because embolization is going to lead to an increase in cerebral and therefore systemic vascular resistance, because we've gotten rid of that low resistant vacuum. This phenomenon is likely going to be exaggerated by the number of feeding vessels embolized. The resultant augmentation in LV afterload leads to increased left atrial pressures. And these increases in LV afterload, especially in the setting of systemic hypertension, which is compounded by the upregulation of the RAS system, can lead to impaired LV systolic performance. Left untreated, these patients can develop low cardiac output state and respiratory failure secondary to pulmonary venous hypertension. So here at Iowa, during embolization, we have a T&E evaluation during the procedure in order to help guide the total number of feeder vessels embolized at one time. Again, this is a balancing act where we want to target enough vessels to decrease the flow to the vein of Galen and resolve the systemic steal and the resultant pulmonary hypertension, while not substantially increasing the afterload to the LV in order to avoid LV failure. Therefore, in order to successfully reduce the overall flow to the vein of Galen malformation, in order to be able to safely discharge the patient home, we need to do this in multiple staged embolizations. Frequently, in severe cases, these patients will need a repeat embolization within the next week, because again, the goal is a staged intervention in order to allow time to have the LV to adapt to this increased afterload gradually, and therefore to avoid LV failure. So how do we assess this in real time? So during the embolization, after a few vessels are embolized, depends on the malformation and in talks with the neurointerventional radiologist. Typically, it's after maybe 1 or 2 feeder vessels. A repeat T&E occurs in the IR suite, and we're focusing on assessment of the LV. So we'll do Simpson's biplane, tissue Dopplers, looking at diastolic markers like IVRT, E to E primes, LV strain. We also assess the burden of flow by assessing what does the SVC flow look like? What is that VTI, knowing what it had been, looking at how much reversal of flow is in the arch. And again, we're back to a balancing act where we want to target enough vessels in order to decrease the flow while not increasing the afterload to the LV so much that we would lead to LV failure. What we want is we want to avoid having a patient come back to the NICU with echo images seen below. We don't want a patient with a Simpson's of 35% and LV strains that are -10 or worse. So the goal of early post-interventional T&E is then to guide the use of systemic vasodilators such as intravenous milrinone. We want to modulate the increased LV afterload and upregulation of the RAS system. And milrinone is a really ideal drug in this case, but we need to have continued close monitoring of blood pressure. We don't want to see swings in our blood pressures, and so we'll carefully titrate the milrinone after starting it. And once the baby has come back from the IR suite, like I said, we'll perform a repeat T&E and continue to follow those echo markers, at least usually daily, looking and monitoring how the LV is coping with both systolic and diastolic function. And finally, we use T&E in post-intervention in order to help determine the timing of repeat embolization if it is needed. So briefly, what is the future of vein of Galen care, and what can we do in order to continue to improve our outcomes? So before endovascular techniques, mortality was reported up to 80 to 100% with neurosurgical intervention only. Since the 1990s, with endovascular treatment, mortality has improved. This was a paper back from 2006, so a while ago now, and it followed patients from 1981 to 2002, so it did see both cohorts. And in this case, in this study, there was a 10% mortality rate overall, but those who underwent embolization as neonates had a 52% mortality. Outcomes in this paper, the neurodevelopmental outcomes, 75% had normal neurodevelopmental outcomes, but that still meant that there was 25% with either moderate or severe neurodevelopmental impairment. And again, this was all encompassing of neonates, infants, and children. They didn't break down just the neonatal outcomes. So what can we do in order to improve both the morbidity and mortality of neonates with vein of Galen? And one of the first steps is to have a multidisciplinary team approach, like many centers do, and the University of Iowa has as well. So we have our Iowa's neonatal, we call it our cerebrovascular anomalies program because we don't just take care of vein of Galen patients. But this is made up with neonatologists. We have our neurocritical care team with both neonatologists and neurologists. We have our neurointerventional radiologists, as well as our pediatric neurosurgeons, and our neonatal hemodynamics team, all taking care of these patients, having many bedside meetings, talking about the physiology, talking about the patient, determining what are the best steps, when is it time to go to embolization, when do we need to repeat embolization, and we continue to follow these patients once they go home. In both neurology as well as outpatient hemodynamics clinic, and our neuro IR colleagues and neurosurgeons follow. And sometimes these patients are still going to need repeat embolizations after the NICU. So that includes getting our PICU attendings involved because frequently they will need interventions later on past the neonatal period. And finally, remember I spoke earlier about how in the fetal period, the low resistance placental circulation balances the low resistance systemic shunt in vein of Galen, which is likely protective of the fetus from heart failure. And it's not until after birth that we see those changes in systemic and pulmonary vascular resistance that lead to significant hemodynamic changes in the early neonatal period. What if we're able to intervene before that happens? So Boston's Children's Hospital and Brigham and Women's Hospital has performed a successful in utero embolization of vein of Galen as part of a clinical trial. And I think I also read recently somewhere in France had recently done one as well. And this approach has the potential to mark a shift in managing vein of Galen malformation, markedly reducing the risk of long-term brain damage, disability, or death among these infants. But further studies are needed, and there is the potential for complications just from any sort of fetal surgery, preterm birth, PPROM, things like that. But one of the more subtle things that I just tended to think about was, what are the implications to that fetus's developing heart with these interventions? Are we going to see that there's going to be those changes in afterload in utero? And is that going to have potential implications on the developing fetus, potentially like what we see in our twin-twin transfusion patients, in particular the recipient twin? Obviously, we need more longer-term neurodevelopmental and cardiovascular outcomes to see what is the future of this. And with that, I thank you all for this talk and excited to be part of the panel and have questions.
Oh, Pearl, you could make it fantastic.
Thank you so much, Amy, for such a wonderful talk. Let me introduce my co-moderator, Dr. Amir Ashrafi, who will be moderating this session with me. And please allow me to also introduce our esteemed panelists, Dr. Angelica Vasquez, Dr. Johanna Fifi, and Dr. Mary Mullen. Dr. Vasquez is a neonatal cardiac intensivist at Columbia University Medical Center. Her areas of academic focus include cardiac and cerebral hemodynamics and the use of non-invasive clinical monitoring tools to optimize the care of premature and critically ill neonates. Dr. Fifi is a professor of neurology, neurosurgery, and radiology at the Icahn School of Medicine at Mount Sinai. She is also Associate Director of the Cerebrovascular Center and Director of the Pediatric Neuroendovascular Program. Finally is Dr. Mullen, who is a Senior Associate Cardiologist and Director of the Pulmonary Hypertension Service at Boston Children's Hospital.
All right, Amy, that was absolutely fantastic. Thank you so much for doing that for us. And to the panelists, thank you for coming on. Pearl had texted me that she's on service and had a medical emergency, so she was able to save a life and come back in time. Excellent job, Pearl. We have an hour to talk about this. This is very complex, so I'm glad we have time. And I thought we could break it down into segments. Let's talk in fetal diagnostics, postnatal diagnostics, medical management, and then intervention, if everybody's okay with that game plan. And I'll first just start with opening it up to the panelists and just start broad. Where are we in terms of fetal diagnostics? I know, Dr. Fifi, you see a lot of these patients when it gets time to intervention, but to everybody, is this predominantly a fetal diagnosis or is this predominantly a postnatal diagnosis in your experience? And where can we improve?
So I can just talk about my experiences. The interventionalists we get referred patients nowadays most typically in utero. I think that screening ultrasounds often pick this up, and so typically around the later, like the second or usually around the second trimester, like late 20 weeks or 32 weeks, something like that. So you know, of the last I would say in the last couple of years, most over 90% of the neonates that we've seen have been diagnosed before birth.
And what does your fetal counseling look like? What kind of numbers and what kind of statistics and what do you tell these families when you're meeting with them?
So yeah, it really, you know, we do fetal echo and then fetal MRI, and we use that to guide the conversation. And yeah, if the brain is normal, as it is in most of the time, obviously if it's abnormal, then there's a whole different conversation. But if it's normal brain, and we get some guidance from the fetal echo specialist, you know, what the flow looks like, if it looks like, you know, some sort of inkling that if it's going to be severe at birth or not. And so yeah, we generally you know, tell the patients or the parents that that it's about when these babies are born, more than 50%. You know, it's kind of like you said, three groups. Some patients don't need any treatment at all. I would say more than 50% need treatment that we're seeing in utero when they're born in high output cardiac failure, and so they need treatment. And then there's a certain percentage, the smaller percentage, that's you know, hard to give the exact number, but that will, when they're born, their brain will have suffered, you know, perinatal infarcts, and then therefore we won't, you know, potentially offer treatment at that time. I would say those numbers are a little unclear. We're actually currently analyzing our numbers to see, but it's probably, you know if you guys have a feeling, but I would say it's probably on the range of 15% that end up like that.
Okay.
And so yeah, and then if they need treatment, then we, you know, there's a whole varied outcomes that can happen. I think more than 50% of the time, though, they do have a good outcome ultimately.
Thank you, Dr. Fifi.
Yeah.
might ask Dr. Mullen next regarding, I know that Dr. Stanford has mentioned about fetal intervention that was performed at Boston Children before. I'm just wondering if you can share with us a little bit about the experience or the knowledge that you have gained, that your institution have gained during like the fetal intervention and between like in utero and postnatal finding on the echocardiography on like or the hemodynamics difference between in utero and postnatal.
Sure. You know, those are excellent questions. We have an incipient fetal malformation program, and really it's based on fetal diagnosis. So over the years, our fetal diagnosis has really increased, and I agree that in the past few years, the great majority of our patients have had a fetal diagnosis. And the series that we looked at a few years back, it was about 3/4 of the patients, but it's really increased to encompass most of the patients that we see. And one of the things that we do beforehand is to try to utilize some prognostic factors to see whether patients are at risk of, you know, aggressive, of heart failure and of a need of aggressive treatment. And so for those who might fall into that category, we have offered fetal intervention. It's very hard to extrapolate because the number is very small so far, but clearly it's been successful. And I think what we really need to do is to try to carefully understand the hemodynamics and how it's different to interrupt that low resistance circuit in utero, and how to manage these patients postnatally as well, because some of them still require additional interventions. So I think this is something that we are really trying to understand very carefully from all of us here in Boston as a group.
Excellent. Yeah, and I think that's really where a lot of, not just vein of Galen, a lot of neonatology is moving more towards the fetal realm and bridging that continuum from fetal to postnatal. Now, let's kind of move the conversation forward. We did talk a little bit about fetal diagnostics. Now, let's say baby doesn't get picked up in the prenatal period, and in the postnatal period, you start to notice these type of abnormal physiologic states. Let me turn it over to Dr. Angelica Vasquez. What kind of things, let's just say you're not aware, and I know Amy Stafford talked about it, but you're not aware that you have a vein of Galen malformation in being delivered. What are some of the hemodynamic clues that people should look for their antennas to go up to and say, wait a minute, this isn't a normal baby?
Hi. So that's a great question. And I think a lot of it, it's sort of, I think one of the things that we're sort of highly emphasized during this talk is that there can be obviously varying sort of underlying phenotypes. But I think for the most part, when we are dealing with a vein of Galen baby, frequently we find that the babies are hypoxic. And so one of the things that can sort of help us in terms of delineating their physiology is doing other things that we sort of do intuitively as neonatologists, such as looking at your pre and post ductal sac gradients. You're looking at assessments of whether the baby, we're in an institution where we use a lot of renal nears, for example. And so those are as another way of sort of being able to use a bedside assessment to sort of non-invasively tell you whether the baby is sick or not. And so I think for these babies, we would also have a low threshold to, if there are signs of hypoxia, concerns for pulmonary hypertension, a baby that has evidence of compromised perfusion, especially in those babies that are presenting with that sort of more pseudocoarctation physiology. Those are babies that I think there would be heightened sort of awareness that the baby was unwell. And so that would trigger, we would have a low threshold to trigger either a pediatric echocardiogram or a TN echo at our bedside at our institution.
In my brain, I always think of these, any sort of AV malformations. Also, one of the clinical clues is a very wide pulse pressure, and there's not too many things that are going to give you a really wide pulse pressure. So these are just clues you can think of that something isn't exactly right. But you touched on NIRS, and I started thinking, I don't know the answer. Maybe you guys can help me. Would my cerebral NIRS be high because of too much cerebral blood flow, or low because it's too much vein of Galen cerebral blood flow and not parenchymal blood flow? I'm just trying to think, what would my NIRS look like in this situation? I don't actually think I know.
I'll be honest, I haven't had too many with the cerebral NIRS, but I think a lot of times in these kids, you would be having, if you're having evidence of heart failure, for example, you're going to have decreased renal NIRS, for example, and evidence of increased extraction from a cellular level. And so I would anticipate that you would, even looking at the lower renal NIRS, would sort of trigger you that the baby was unwell for some reason. It might not necessarily tell you that there is an obvious vein of Galen malformation, but
yeah, it triggers the workup.
Mhm.
What do you think, Dr. Mullen? What are, again, I'm just for my own interest. Would my cerebral NIRS, in your opinion, you think they would go up, or do you think they would go down on this physiologic state? You take a
Well,
lot.
it's a really interesting question, because you certainly have an arterial steal going on, and you may have neurologic injury in that setting, but at the same time, there's a lot of blood flow. So I think it's a really good question.
Maybe cerebral NIRS isn't the diagnostic test of choice. I'll turn it over to Pearl if you have any other questions, Pearl.
I was just going to say that sometimes we don't make the diagnosis until the infant is actually in the cath lab, and we get a very high mixed venous saturation as we start the procedure, and that's really a clue that there is a tremendous shunt that's going on.
That's actually an excellent point. Can you take a deeper dive into that mixed venous sat and just kind of explain to our audience what exactly you're looking for when you get that that value? And how we could
oh, go ahead. And how we could, so the first thing is we're really thinking about what is our, we use it as a surrogate of cardiac output. And so it's really the first measurement that we obtained as you enter the heart to get an SVC and then a right atrial saturation. And so if it's quite high, very elevated, you're thinking like, where is that blood coming from? Why is there high oxygenation? And it's really because of some form of steal or shunt. In contrast, if it's very low, you would think that an infant has very low cardiac output.
So yeah, so at the bedside, you get a blood gas from your UAC, you get a blood gas from your UVC, and they're strikingly similar. You have to think, wait a second, what's going on over here? Yeah. Sorry, take it away, Pearl.
Yeah, good point.
Then I think we did touch a little bit about like the post intervention or post embolization cardiac hemodynamic changes that can lead to left ventricular systolic dysfunction. I would like to direct this question to Dr. Stanford. Do you expect to see similar changes of the left ventricle if the intervention is done fetally or in utero?
That's a great question, and that was one of the things that I was thinking about when I heard about the in utero interventions. And I think we just don't know enough to know what is going to happen. I think the thing that I can see it is potentially more like what we see in our twin transfusion patients after they're born, where they're doing all right in utero, but then now they're born and we're seeing these changes in systemic and vascular resistance. And there are potential implications to the LV in utero that potentially they're not going to tolerate that increased afterload. But I don't think we know enough yet about what we can see. I do have to make one plug about diagnosing these prenatally when you don't, or diagnosing them postnatally. And I have to give a shout out to one of my mentors, Dr. John Daigle, who listens to every baby's head that he admits. And every baby who's had a vein of Galen, we have heard a bruit on. So making sure that we're still at the bedside listening to our patients and examining them. So.
And I think it leads to one of the questions that our audience has submitted. They said that in patients that were not diagnosed prenatally, how soon after birth do we usually see them become symptomatic or hypoxic? so from you guys' experience, do you see them becoming very symptomatic pretty quickly after birth?
I think we're pretty unlucky here at Iowa in that a lot of the cases that we have taken care of with vein of Galen's have been undiagnosed, whether that's because of lack of prenatal care or whatnot. And most of these patients are symptomatic right at birth. Typically, I feel like they're not quite as sick as some, like say our like meconium aspiration, acute pulmonary hypertension patients. And I think probably a lot of that is due to the lack of lung disease. And so not having that combined effect is what I think they're a little more stable initially. But the 4 or 5 that we've had recently that have been undiagnosed prenatally were symptomatic at birth.
I just wanted to say, I think there's a spectrum of, of presentation. And so there certainly are babies that, at one end can be very sick and have a lot of retrograde flow, impaired coronary perfusion and really present in shock. But at the other end, there are babies that can, be mildly tachypnic or really even asymptomatic, in whom the diagnosis is found later on. So I do think for those who are not prenatally diagnosed, there is a spectrum of presentation.
Yeah, I think I was actually going to say that exact point. How quickly they present probably depends on how hemodynamically significant and how large this AVM is. And I just wanted to make sure that all of our audience, I know you guys are the experts, and so you throw a lot of terms out and you don't think much of it. Just make sure that everybody's on the same level. We're all familiar with heart failure being that an LV or an RV doesn't squeeze particularly well, poor contractile force. But what do you mean when you say high output failure? What exactly is high output heart failure? Anybody? All right, bad question. Should we go to the next question?
I guess we've actually gotten away from utilizing that term because I feel like it is confusing to
I agree with you.
keep going.
With that.
So we've actually gotten away from really utilizing it unless what we see on the echo is some sort of dysfunction, and really discussing more about what is the actual underlying physiology. So, when you say high output cardiac failure, usually what people are talking about is then that the flow mediated pulmonary hypertension. But we have really tried to get away from just utilizing that unless what we're seeing is actual like LV or RV dysfunction.
Yeah.
Dr. Shaking
I was just going to say it is a confusing term. I mean, the differential for high output, includes thyrotoxicosis or patients with other AVMs or liver disease. And, it really goes back a little bit to that mixed venous saturation, but it is a term that leads to confusion. So we don't use it that much either.
And I know it feels like we're leaving the neurointerventional radiologist out. I promise we'll get to you soon, Dr. Fifi. Dr. Vasquez, in your institution, your Columbia, you work in their cardiac NICU. Do you guys still use the term high output failure? Are you starting to deviate away from it? Is it still part of your vernacular? How do you guys? I always found this to be a confusing word as well.
Yeah. I mean, I'm sure it gets thrown around regardless, because let's be real. But I agree that exactly as Amy was saying, the important thing is sort of understanding what is the underlying phenotype. And I think in general, when we're using that term, we're really just referring, it might not be sort of intrinsic systolic or diastolic dysfunction that is sort of inherent in that baby's myocardium, but rather a state where the heart, for example, is working extremely hard and not able to keep up with the demands. And so it's all about supply and demand and an imbalance in that state.
Completely agree. Making sure that our DO2 is adequate to meet the demands of the VO2. I'm going to ask one more question, Pearl, if you don't mind, and I'll turn it over to you. That sort of segues into this next question by Arima Nigpal, which is what I wanted to ask you as well, Amy. You talk about flow-driven and resistance-driven pH in this physiologic subtype. Is that a continuum, or is it isolated. You have flow, you have resistance, and they're two very separate phenomena in disease processes, or does one lead into another and they're on a spectrum together?
It's a great question. And, in reality, it's not just as simple as either having resistance or flow. And we frequently see in these patients, it's a combination. And so it's trying to find that balancing act of they might have resistance mediated and treating that enough to allow us to increase our, left ventricular output. But when we treat it too much, then we switch over. And this is what makes these cases really complicated, is that it's not just black and white, it's this gray area, and that it's really a mixed phenotype that we see.
Yeah. Amy, I wanted to ask you, do you ever see other conditions that, cause more of that blurring between high flow and high resistance, like IUGR or prematurity or other issues that might contribute?
Yeah, definitely. So like you said, in those patients who maybe are at increased risk for having resistance mediated disease, like you said, the IUGR, being born early, pneumonia, meconium aspiration, that can really just complicate the picture even more. And so that's why it takes several, especially in those sickest of the sick, it takes days for us to really kind of tease out exactly what is that underlying physiology, what's going to get better and what's not going to get better, and what's and when they're ready for intervention.
And I think this questions will actually, like, for any of the panelists as well. I think one of the audience is wondering, like, apart from vein of Galen malformation, would any other AVM in any other parts of the body like present similarly if it's big enough? Like, for example, if AVM in the limbs or like the AVM in the liver, would we expect the presentation to be similar?
I would say that there are aspects which are similar in terms of the high output and the potential for high output failure, and how you balance systemic oxygen delivery and shunt. But there are particular aspects of the cerebral AVM that and the runoff in the aorta that involve perfusion of the arch and perfusion of the coronaries that I think are somewhat unique to vein of Galen, shared potentially by other large cerebral AVMs. But I'd be interested in others' experience.
I can give my.
Oh,
Go ahead.
No, go ahead. You go. We've had a few cases of like hepatic AVMs that have not presented, as ill. Those are frequently been picked up in utero, and then it's just kind of a balancing act in those cases, more so about what is like the gut perfusion and things like that. We've had a few just other vascular anomalies in the brain, but the hepatic AVMs have different things on the echo phenotypes that we monitor.
Yeah. And even though the underlying genotype may be similar, I think pulmonary AVMs are very different and present in a very different fashion.
Very good point. We have about 30 minutes left, so I just want to ask one more medical question, and then let's move to the interventional arm of things. There's one thing you said, Amy, that caught my attention, the use of milrinone in these patients. I will be honest, I haven't used milrinone in these patients. If I had a baby, wide pulse pressure, I think I would be nervous in giving a systemic vasodilator. Now, I understand the concept of it. Again, you're trying to balance where blood flow goes. But what's your guys' experience been with milrinone? Am I being scared for no reason? Or have you guys also found that it's a little bit tenuous? Or what's your experience been with milrinone?
Usually when we're using milrinone in these patients is after the intervention, not so much in the pre intervention. If we felt like we needed to, I think you have to be cautious knowing whether there's been any sort of renal lack of
Agreed.
renal perfusion, because since the milrinone is excreted renally, you'd have to be really cautious. In other cases where we felt like we've needed to use milrinone, not in vein of Galen, we haven't needed to, but where we're a little bit cautious about what is our kidney function, we start really low doses. So we'll start at like 0.2, 0.25, and be really cautious in the increases.
Yeah.
That makes so much sense. Go ahead, Dr. Mullen.
Yeah, I would agree that I think after intervention, milrinone can be a great drug, but has to be used judiciously. I mean, it's a type 3 phosphodiesterase inhibitor, and so it really has effects on inotrophy and as well as SVR, luciotrophy, and it has some effects on the pulmonary vasculature. But it certainly can improve systemic perfusion, particularly after intervention. And so we frequently use it in that setting.
If I misunderstood you, Amy, I'm sorry. I thought you said you use it pre. I didn't realize you said it after in your presentation. I apologize. Go ahead, Pearl. Maybe we can keep moving the conversation and go to intervention. What do you think with the time we have left?
Yeah, so I know that Dr. McNamara has like one burning questions that he would like to ask, but I'll finish with the question for Kelly Mayer. This question will go to Dr. Fifi actually. She's wondering like what would be your consideration like in terms of size or the baby's weight or like the cutoff that you will use to determine embolization like candidates for embolization. So like when neonatologists call you, what should we be telling you in terms of helping with the decision making?
I mean, it's in terms of size, it's for us, it's the bigger the better. So you know, when we diagnose in utero, we try to bring them as close to term as is safe and as possible. You know, we usually do plan to have them induced or deliver like around 38, 39 weeks, just to avoid spontaneous deliveries and in you know people that may be living far away, things like that. Yeah, so you know, I would say that if they're really, we don't have very good luck with premature babies, so we do use umbilical artery access to get up to the head to do the embolization, but you know, we try to. If they're diagnosed beforehand, we can plan that. If they're diagnosed after, sometimes it's not possible. But but I would say like anything, you know, most of the babies are around 4 kilos, 5 kilos, something like that. If you go to 3, that's I don't think we've had any good outcomes with babies that small. Yeah, like if you go to like 2, we've had a couple babies like 2 point something, and I think those were tough cases and more complications.
You said a couple things that caught my ear, Dr. Fifi. I didn't even think about it until you said it. If the concern is steel, and so you don't have adequate DO2 to brain tissue, wouldn't it make more sense to deliver them earlier and intervene earlier, especially if we do have the capability to do fetal intervention, so size shouldn't be the limitation? Or maybe I'm not understanding, why can we do a fetal intervention on low size, but not a postnatal intervention on low size? And maybe we should deliver them a little bit earlier, 3 weeks, 4 weeks. I'm not saying extreme prematurity, but does that make any sense? Or why is there, I guess I'm asking 2 questions. Does it make sense to deliver them earlier to prevent steel to the brain tissue and try to maintain as much white matter as possible? And number 2, if we can do it fetally, if size is not a limitation fetally, why is size a limitation postnatally?
So yeah, the first question, yeah, the steel I think is not, it's a small percentage of patients that end up having like severe, what we call brain melting before birth. And I agree, though, that probably does happen in the last few weeks. But yeah, to balance it out, I think the hemorrhagic complication rates are higher. I don't know if, if the vessels are more fragile, the earlier, it kind of, it may make sense. But yeah, part of it is actually the size getting, especially if you have to go transfemoral or something like that, getting into the vasculature. The fetal intervention is different than the intervention that we usually undertake. So it's a long story, but I think Dr. Mullen probably knows what they're doing better. But in the fetal intervention, they're filling the vein of Galen with coils, and partially filling them with coils so as to slow the flow down, and but not completely close the entire thing. And that's not usually what we do in the neonate. We try to close the arterial feeders to the malformation. And so it's a different, it's a different procedure. I mean, back in, when this was first, endovascular embolization was first being done in the late 80s, that was the procedure. It was really the only procedure that could be done because of the device technology that was available back then. And so filling the big sac with coils worked sometimes, but it really didn't have as high a degree of success, because if you do that and you cause thrombosis of the entire malformation at once, that can cause neurological issues. You can have hemorrhage into the brain. You just didn't end up with neurodevelopmentally normal kids. And so whether we I've thought about recently whether we could go back to that. So the idea of the fetal intervention is really to try to have the baby be born in a more stable condition, in the most severe cases. And so this is sort of a different strategy than when we have a neonate and we're trying to get them out of heart failure and out of the hospital. We're trying to close specific arterial feeders. So it's a little
Makes sense. Thank you for clarifying that.
I had a comment about one of the questions before, what about the babies that were, like, when do they become symptomatic? I totally agree with Dr. Mullen. It's a huge range, and some babies don't even get diagnosed till they're older. But it seems that oftentimes, or a lot of the times, and maybe it's because of the pulmonary vascular resistance and the patent ductus, that they're born okay, and we're watching, and then about day 2 or 3, that's when things start going a little, downhill. And I'm sure, you guys have a far deeper understanding of the physiology that produces that, but it seems that that seems to be a pattern that we often around day 3 or like we're thinking, okay, it looks like we have to do something. And
I know that.
I was going to say, it just has to do, I think it has to do with transitional physiology, that the pulmonary vascular resistance reduces and the duct may get smaller, at that point. And somehow that brings babies to presentation. But I agree, we see that too, around day 2 to 3, even prenatally diagnosed, we're following very carefully, and then really see that the baby starts to become symptomatic.
Yeah, these babies, and Dr. Stafford mentioned these babies, this is a ductal dependent lesion in the most severe cases. The PGE is not just for babies with congenital heart disease. There are babies like this that also need that ductal patency. Take it away, Pearl.
Okay, so I think lastly, we would like to invite Dr. McNamara, who is to ask his questions as well.
Thanks, Pearl. Apologies if you hear some noise in the background. Someone is drilling or something here upstairs. So I want to thank everyone for this wonderfully engaging kind of discussion. I think, it's really, really important that we talk about niche conditions like this. And my question relates to that one specific topic. If we look at the world of reality, we listened to Amy talk about the complex physiology, the dynamic nature, the difference in phenotypes, etc. And we look at interventions and we learn from many other things, PDA closure, volume is everything. And then we look at the world, and particularly in the United States, and we have these babies being born, oftentimes in places in which it's a postnatal diagnosis, or maybe sometimes a fetal diagnosis, and there may not necessarily be the degree of expertise to think about the hemodynamics in a much more thoughtful way. And you may have individuals that may have marked varied expertise that do this very infrequently. How do we change the paradigm? Okay, we have some centers of excellence, but as a country, we don't have a strategy for managing this condition here. So, again, I did a survey here, to look at what does it look like in the Midwest, and it's like in most places, one intervention might be done once in the year, or maybe in every 18 months. And some of these are big centers, okay? We know that that's not good. And then oftentimes you hear the story, well, we can't move the patient to another more expert center because the babies are too sick, which probably may come down to maybe the wrong therapy is being given. And I've seen in my career, babies become profoundly unwell with nitric oxide or vice versa, So, and again, we've got a great expert panel here. My question really is, how do we develop a strategy for the country? So logic would say you want to put centers in different places around the country with the appropriate intervention expertise, with cardiovascular expertise, etc. Where do we go from here? So, not an easy question, but I think it's an important question to talk about here because people think that they can manage these babies. They're not easy. So, I don't know who wants to have a go at that. It's kind of political too. Sorry, but this is a good session.
I don't have an answer for you. It's an excellent question. It's an important question. And I'm going to sort of segue into Dr. Mullen as well, because in the congenital heart world, there are areas of regionalization. I think they've done a great job of that. Boston being a pulmonary vein center. Anybody with pulmonary vein disease, you go there. Stanford has got a very good MAPIS program. You go there. So I think it's been pretty well established in the congenital heart world, but I don't even think in the NICU world we really do regionalization for any diagnosis, do we? Other than kind of a spoken wheel model that a lot of centers have. We're the main children's hospital. We'll have a bunch of partners and we're the spoke, they're the hubs, and send everybody to us. But I don't know about a national regionalization within the field of neonatology.
I don't know how many, maybe Mary will know, how many cases are there in the country? And again, the problem is we may not necessarily know the answer to that because maybe babies are dying in places and it just is not obvious. And is there a need for a national registry?
Right. I mean, I think that there probably is a need for a national registry because, certainly, an infant is born in a center, a community center, then goes to a regional center, but then may need to be transported again to a center that really cares for of excellence for caring for these babies. And I think that there are many complicated decisions, and you would like to have a clear network of support and clear plan for that. I agree, Patrick, completely.
Yeah, and the other thing too as well is that, again, certainly just thinking of our region here in the Midwest, not every family can also go from a financial perspective. They may not be able to travel, so kind of, it just, and we hear that from families, and that's an awful situation because none of us would want a procedure being done by someone who does it incredibly infrequently. We wouldn't accept that ourselves.
Yes. And there should be a way to bring those babies back also for, repeat assessment and intervention and, maybe even neuro, developmental follow-up. And not to mention cardiac.
Yeah, absolutely.
Yeah, I think it's in the UK, for instance, they obviously that's a national healthcare system that they can make decisions across the whole country or multiple countries, but they have 2 centers that deal with vein of Galen malformation, and anyone diagnosed within this NHS will go to those 2 centers. So, but in the US, it's really, it's not controllable. I think that we've found as neurointerventionists, there's a limited number of us, but yet people, we like Dr. Orbach at Boston Children's, and I have gotten referrals from other interventionists that say, hey, can you treat this patient? We don't feel comfortable. But it is an issue because some of the patients come from far away. And if they're not told, we often, when I see these patients, they've been coming, hearing of us through, interestingly, social media, because they kind of Google the diagnosis and then come across support groups and talk to other parents. And so there's a couple of parents that have founded a nonprofit to assist patients and their families with, hotels or travel, if needed, to get them to places that have expertise. And so that's one way, but it's certainly not the same as being able to organize it. I don't know how congenital heart, how they did that. Maybe we could learn from them.
I think that there's more volume there, which certainly helps. I think the registry idea is great, but certainly, as we know from other registries, and certainly the transcatheter PDA closure registries, oftentimes you're at the mercy of whether people will enter their complications. That always is one of the worries, that people are happy to enter when things go well, but not happy to put it in when things don't go well, which would be the weakness with the registry. But certainly some form of expert consensus statement around the care of these children in terms of what are the standards to be a center that does this properly. I think that would be a good step forward, because I don't think any society, AAP or anything, is going to come out and decide we want to do vein of Galen. This is one of the first kind of webinars, at least within neonatology. And Amir knows I'm pushing to have this on NeoHeart, etc., to get people out there thinking about this, because it's like anything. It's, people will draw an analogy to CDH. Well, we take care of CDH babies so we can take care of a vein of Galen baby, but they're very different.
Yeah.
Our few minutes. There's a question I've always wondered, I never had the answer to, but again, since we have all the experts here, Dr. Mullen, these babies who do transition to a resistance-mediated PH, intimal hyperplasia, reduced internal diameter, how long is the process to undo what was done? Is it very individualized and very different, or do you know the natural history?
Yeah, I think it is to some extent individualized. And I would say that there may be some other factors that are contributing to that as well. And I would include other shunt lesions, as well as possibly genetic variants, which are associated with vein of Galen, but potentially with other forms of pulmonary hypertension that might contribute. I think we don't clearly know that answer. So some of those things could change the way that resistance-mediated pulmonary hypertension resolves.
And I know we're coming up on time, Patrick. Can I just ask one follow-up question, or even a couple more? Intervention is done, ductus is closed. What is the right pulmonary vasodilator strategy for these babies who continue to have pulmonary hypertension, but it's more of a fixed pH? This is one of these conversations I have in my head all the time. Dynamic pH is easy to manage. You're, one of the best in the field. How do we manage babies with fixed pulmonary vascular disease? And I know it's a very
Great.
question.
I mean,
That's very
it's a terrific question. So in terms of these babies, and Dr. Fifi can comment on this, but often there still is a residual shunt. It's not always completely 100%. It's not as if it's completely closed. But we like to use pulmonary hypertension or some of our markers, our echocardiographic markers, to say that the degree of shunt has decreased to an extent which is manageable and which doesn't cause high output. How much is that? That's a real, it's a very challenging question. So we've started to look by MRI at a series of patients to try to understand how much do you really have to close the shunt in order for the pulmonary hypertension to decrease? Like what is that barrier? And are there other things that an infant might have to go home on because they have resistance mediated pH, maybe due to some other contributing factor like prematurity, like some issues with the lungs, and they might end up going home on oxygen. So there are a couple of other factors that are in there, or do they have a genetic variant? Do they have ACVRL1 and might have long-standing pulmonary hypertension? Or if we can pay attention to that and make sure that they're not hypoxic, if the shunt is decreased, then they won't. It's a great question, and I think it's one of the major questions in this field. Are there prognostic value in some of the genotypes that you can separate things out, or are there other things that contribute to that high resistance pulmonary hypertension?
Yeah, a precision
there we go.
is the right one.
And if I could just ask this panel, because it's my other question that I'm really interested in is, are there biomarkers that we can use to look at hemodynamics and prognosis? So BNP, lactate, I mean, how do others use those?
That's an excellent question. Angelica, what do you think? How do you guys do it in Colombia?
I admit that I haven't had too many of these since I finished my hemodynamics fellowship, but usually with babies that we're monitoring heart failure or degree of pulmonary hypertension, like one of the only ones that we kind of use, and it's more of a serial trend, is like pro-BNPs, but I don't know that I have a specific number that I use to like prognosticate it, or at least that I'm aware of at this time.
Yeah, we do trend those, and I think it correlates, and we trend the lactates. Yeah, I think we do use lactate a little bit to, if the lactates cannot be controlled, then we lean more towards intervention. And yeah, we don't close the whole shunt at once. Sometimes if it in certain other diseases like peel fistulas, sometimes you have to, it's only one hole, and so when you close it, it closes. But in vein of Galen, we don't, and so they do often, and we come across this question quite often in the neonates. Do they have underlying primary, some other form of pulmonary hypertension, or is it all related to the shunting? And so I work with the neonatologist and our fetal cardiologist who actually follows the patients and the echoes in the neonates after they're born, and she also has these questions, and oftentimes we don't know until later, I think. But then sometimes the patients we think that we've closed, and we look at the VTI ratio in the arch, and to try to get an idea of, did we close enough? We use that a little bit. And sometimes we run into the question, but they still have this pulmonary hypertension, what's going on? And I think we have one patient that actually sees you, Dr. Mullen, now, because she, even after cure, she has pulmonary hypertension. So whether she has some, other genetic disease. So yeah, to me, it's not, but that being that I'm an interventionist, to me, it's confusing at times to understand if there's something else going on besides just the vein of Galen shunting.
I think that just speaks to the need to have a team dedicated to taking care of these patients that are going to look at the patients as a whole, looking and seeing, are we making progress with our respiratory status, with feeding, with growth, in addition to seeing what are their BNP or pro-BNP if you follow those, what is their echo looking like, and continuing to follow those patients after they leave the NICU if they're going to need, future interventions, future medication. And what are these patients going to look like as young adults? We don't know all of those things yet.
Amir, can I just make one just very quick comment, because we do need to wrap up. The one thing that no one really, I'm aware, has paid much attention to is heart development itself, and chronic coronary artery ischemia, and something we do measure troponin and look at that. But the lessons we've learned for the extremely preterms growing up to be adults with heart disease, is there some long-standing impact on kind of RV, LV development that could have repercussions later in life? I think there's just not enough of these patients to know. And I don't know if kind of Mary has any idea from the cohort that you guys have in Boston. You've got the biggest cohort, but is there anything beyond pediatrics for these children as adults to know how are they doing?
Yeah. So we have very few of these patients who are now adults, but there are some structural cardiac issues that undoubtedly reflect the underlying hemodynamics that we have not yet really began to explore at all. So there can be LV dilation, there can be aortic dilation that's long-standing in some of the patients, and I do think it's going to require a combination first of very careful genetic testing, full exome, really to try to understand which patients have genetic variants and which do not. And in those patients, you have to, if they have HHT phenotypes such as endoglin or ACVRL1, you have to look for other forms of shunting. But also, I think that we have to do careful follow-up. And it's hard because if it's difficult to bring babies into one center when they're acutely ill in shock, it's very hard to bring them in when they're pretty much doing well, but you really want to follow them and they're coming from all over the place. And I think, developing that kind of system is really critically important so that we can really understand the results of these interventions. And are there structural changes in the myocardium? We don't yet know from longstanding high output or other things. So really important to do that work.
Yeah, we have a fair number that are not a huge number, but fair number that are adults or in their 20s up to 30, and but it would be great to do a systematic look at the ones that I've seen in the last year. They don't have any long-standing cardiac issues, but I think it would be good to do a systematic study and to really look at that.
I think that's what happened with the preterm babies. Like no one really paid much attention to it till Adam Lewandowski did that study on, it was adult outcomes of breastfeeding with MRI, and started to notice that there were fundamental differences in some of these, preterm babies, and most of them were not sick or unwell, and it probably will be further down the road. It probably will have some form of repercussion, but yeah, I think would be super, super interesting to
it may be possible to look at, because all of our babies go on to get echoes, once they go home, and for a few years at least. So
yeah, I mean, it would be possible for us to combine data with someone, because they continue to have that and to look at.
I think it's about time that we have to wrap things up. Thank you so much, everyone, for such a Amy, for such a wonderful presentation, and all our panelists for such a fruitful discussions. And thank you, Amir, for co-moderating this session with me.
Thank you, everybody. It was a pleasure. Have a good day.
Super. Thanks, everyone.